In this lecture, we discuss the endocrine system, starting with the thyroid disorder. Congenital hypothyroidism. In the beginning, we started to give a short note about the physiology of the thyroid gland. Thyroid gland, it is under the control of the pituitary, and the pituitary gland, it is under the control to the hypothalamus. From the hypothalamus, the TRH, thyroid releasing hormone, it is secreted, which stimulates the pituitary gland to secrete the TSH. And the TSH acts on the thyroid gland, on the target, which is the thyroid gland, for release of the T4 and T3. T4 and T3, when become the level in the serum will be rise up, then this will lead to the feedback mechanism to the pituitary gland and to the hypothalamus. So the TRH and the T4 and T3 working in balance in the circulatory blood. Congenital hypothyroidism occurs in approximately 1 in 4,000 live births and usually not hereditary and a result from thyroid dysgenesis. So the hypothyroidism, it is not hereditary disease and it is a result from the thyroid dysgenesis. Some cases may be familial and usually some cases caused by one of the involved of the thyroid hormone synthesis and may be associated with goiter. Clinical manifestation of the hypothyroidism. In the immediate newborn period usually are subtle, but may become more evident week or month after the birth. So newborn screening is crucial to make an early diagnosis and initiate thyroid replacement therapy by younger than the 1 month of the age and in the absence of the definitive sign. So it is very important to do screening tests for the hypothyroidism before the appearance of definitive signs, because this may lead to the bad complication or bad sign of symptom of hypothyroidism. Congenital hypothyroidism, it is rise as common in girl as in boy, and birth weight and length are normal, but the head size may be slightly increased because of the myxedema of the brain. Affected infants cry little, sleep much, with lack of interest, and are generally sluggish. So the infant, it is cry little, but more sleep, is less active, lack of interest, and usually the birth weight and the length are the normal, but the head size may be increased slightly because of myxedema of the brain. Respiratory difficulties due to in part to the large tongue, including apnea episodes and noisy respiration and nasal obstruction. Typically, respiratory distress syndrome may also occur. Prolongation of the physiological jaundice caused by the delayed maturation of the glucuronide conjugation may be earlier sign. Feeding difficulties, poor appetite, and choking spells during nursing are often present during the first month of life. There may be constipation that is not usually respond to treatment, and the abdomen is large and umbilical hernia is usually present. So there will be, if there is sign of respiratory distress, apneic episode, umbilical hernia, prolonged jaundice, constipation, and umbilical hernia, all these features if present in the infant or the neonate, so we have to think about the hypothyroidism. The temperature is subnormal and often less than 35 centigrade. The pulse is slow, and there is heart murmurs, cardiomegaly, and asymptomatic pericardial effusion, which are common. Macrocytic anemia is often present, and it is refractory to treatment with hematinic therapy. The child growth will be stunted, and the extremities are short, and the hand are broad, and the finger are short also. The anterior and the posterior fontanelles are open widely. The eye appear far apart, and the bridge of the broad nose is depressed. The mouth is kept open, and the thick, broad tongue protrude. Dentation will be delayed. So the patient, when we have respiratory distress, ethnic attack, and there will be abnormal temperature, subnormal temperature with heart murmur, cardiomegaly, refractory anemia, stunted growth with broad, short hand and short fingers. The anterior and the posterior fontanelle are open widely, and the eye appear far away, and the bridge of the nasal bridge are depressed. The mouth open with thick, broad tongue, dentation delay. All these clinical picture when collected together, then this is suspected for the high case of the hypothyroidism. This is the picture of the unit show with the feature of the hypothyroidism. So head slightly is large, the nasal bridge is flat or depressed, eye far away, and there is a protruded tongue with thick, and the mouth is kept open. The neck is short and thick. The skin is dry, scaly, and there is little perspiration. Also, there will be cold and mottled skin, particularly that of the extremities. The edema of the genitals and extremities may be present. Carotinemia may cause a yellow discoloration of the skin, but the sclera remain white, so this is differentiated from the jaundice, where the sclera it is yellow also in case of jaundice. The scalp is thick and the hairs coarse, brittle, scanty. The hairline reach far down on the forehead, which usually appear wrinkled, especially when the infant cries. The voice is hoarse, and they do not learn to talk, so there is a form of the speech difficulties. Sexual maturation delayed or may not take place at all. There is a slight excess of other congenital abnormalities, especially the heart defect. Laboratory finding on congenital hypothyroidism: serum level of T4 or free T4 are low. Serum level of T3 may be normal and are not helpful in the diagnosis. So T4 it is most helpful in the diagnosis rather than T3. If the defect is primary in the thyroid, level of TSH are elevated and often to greater than 100 microunit per liter. Serum level of prolactin are elevated, correlated with those of TSH. Epiphyseal dysgenesis, deformity, peaking of the 12th thoracic or first and second lumbar vertebra is common. So the main laboratory finding of hypothyroidism is serum level of T4 or free T4 are low with increased TSH. This is the main diagnostic or laboratory finding in the congenital hypothyroidism. ECG frequently show low voltage. In children older than the 2 years of age, the serum cholesterol level usually elevated. So there is T4 or T4 low with elevated TSH with epiphyseal dysgenesis with ECG show low voltage, and in children over the 2 years of age the serum cholesterol level is usually elevated. And this is the picture of congenital hyperthyroidism. Show in picture A, absence of the distal femoral epiphysis. Absence of the distal, this is the distal femoral epiphysis. It is absent, it's not found in a 3-year-old infant who has born at term. B, there will be epiphyseal dysgenesis in the head of the this is the epiphyseal dysgenesis in the head of the humerus in 9-old girl. So there is absent of the femoral epiphysis in the picture A, where in the picture B show the epiphyseal dysgenesis. Treatment: levothyroxine given orally in the treatment of the choice. In the unit, the initial starting dose is 10 to 15 microgram per kg. The level of the T4 and TSH should be monitored at recommended interval, usually monthly in the first 6 months of life, then every 2 to 3 months between the 6 months and the 2 years. So we have to starting with 10 to 15 microgram per kg and monitoring of the T4 in a monthly interval in the first 6 months of life, then after that every 3 months between the 6 months and 2 years, and maintaining in the normal range for the age. Children with hypothyroidism required about 4 microgram per kg per 24 hours, and adult required only 2 microgram per kg per 24 hours. From the neonatal period till to reach the adult, so we have to decrease the dose of the thyroid, starting with 10 to 15 milligram, then subsequently decrease after normalization or maintaining the dose. The children will start with 4 microgram per kg, and in adult require 2 microgram per kg. This is the picture or feature of congenital hypothyroidism in the infant, with showing the all feature mentioned before. This is coarse hair with hairline. It is down to the forehead. Eyes, it is apart, far away, flat nasal bridge, mucoedematous face, protruded tongue with thick. Prognosis: with the advent of the neonatal screening program for detection of the congenital hypothyroidism, the prognosis for affected infant has improved dramatically. Early diagnosis: this is important point. Early diagnosis and adequate treatment from the first week of life result in the normal linear growth and intelligence comparable with that of unaffected siblings. Without treatment, the affected infant are profoundly mentally deficient and growth retarded. Other disorder of the endocrine disorder: ambiguous genitalia. And ambiguous genitalia mean distorted of the external genitalia, so abnormalities in the structure or the external shape of the genitalia. This is non-ambiguous genitalia, mean distorted of the genitalia. In this slide, show two descriptive disorder. The first one in upper part show this 46XY karyotype. This is 46XY karyotype, means this is male with ambiguous genitalia. This lead to the either incomplete expression or complete phenotypic expression. Incomplete testicular feminization syndrome lead to the short vagina, where complete female phenotypic testicular feminization syndrome lead to the complete phenotypic feature of female, in spite of although the karyotype is XY. 46XY mean male with phenotypic feature of female. Other disorder: karyotype 46XX mean karyotype, it is a female with ambiguous genitalia. This lead to the congenital adrenal hyperplasia, which either be salt losing and non-salt losing. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia, it is a family of the autosomal recessive disorder of cortisol biosynthesis. The cortisol deficiency result in increase in the secretion of the ACTH, corticotrophy. And this increase in the ACTH, which in turn lead to the adrenocortical hyperplasia and overproduction of the intermediate metabolite. So when there is deficiency of the cortisol, this will result in increase the ACTH, and the ACTH in turn lead to the adrenocortical hyperplasia and overproduction of the intermediate metabolite. Depending on the enzymatic steps, which in the next slide will be explained, this enzymatic steps that is deficient, there may be sign and symptom and laboratory finding of the mineralocorticoid deficiency or excess. Incomplete virilization or premature puberty in affected male, and virilization of sexual infantilism in the affected female. So according to the site of steps or steps of the enzymatic deficiency, this will lead to the sign and symptom and laboratory finding of either mineralocorticoid deficiency or excess or incomplete virilization or premature puberty in affected male. This slide show this diagram show the metabolism of the cholesterol. Cholesterol is either metabolized to the progesterone or to the 17-hydroxyprogesterone, and progesterone by the 21 hydroxylase hydroxylated to the aldosterone, and also 21 hydroxylase hydroxylate 17 hydroxyprogesterone to the cortisol. So when there is deficiency of the 21 hydroxylase, so there is a block for the pathway to reach the aldosterone and the cortisol, or by other meaning to form the aldosterone and the cortisol. When there is a block or unformed of the aldosterone and the cortisol in a state of the deficiency of 21 hydroxylase, then the pathway will be returned back to the progesterone and to the 17-hydroxyprogesterone, and these both subsequently lead to the excess of the androgen, and this will affect it on the adrenal and cause hyperaldosteronism. In this slide also we show the metabolism steps of the cholesterol. The cholesterol metabolized to the progesterone and to the 17-hydroxyprogesterone, and by the presence of the 21 hydroxylase, the progesterone will be hydroxylated to the deoxycorticosterone, and then the final pathway reach to the production of the aldosterone. Other lines, the midlines, are also by the presence of the 21 hydroxylase, 17 hydroxyprogesterone will hydroxylate it to the 11 deoxycortisol, and this subsequently lead to the production of the cortisol. When there is deficiency of the 21 hydroxylase, so the final production of the cortisol and aldosterone is felt. This is a clinical condition known as the salt losing state, under the condition of the congenital adrenal hyperplasia, because when there is 21 hydroxylase deficiency, there will be excess of progesterone and 17 hydroxyprogesterone. The pathway will turn back. When there is a closed, there is no 21 hydroxylase, the pathway will block, and then return back to the formation of the progesterone, 17 hydroxyprogesterone, and then it will lead to the androstenedione, and with excess of the ACTH and causing excess of the virilization. There is another disorder or another clinical condition under the congenital adrenal hyperplasia due to the deficiency of the other enzyme, not due to the deficiency of the 21 hydroxylase. Here there is deficiency of the 11 beta hydroxylase. When this deficient enzyme 11 beta hydroxylase, the 17 hydroxyprogesterone, by the presence of the 21 hydroxylase, hydroxylated to the 11 deoxycortisol, and this 11 deoxycortisol, when by the absence of the 11 beta hydroxylase, it is not formed the cortisol. It does not lead to the production of the cortisol, because deficiency in this point, in this step of 11 beta hydroxylase, where the lines of the pathway from the progesterone to the final production of the aldosterone is intact, remain intact. So there is no salt losing. But here cortisol is not present or not of production. This will lead to the salt retention, state of the salt retention. So in this case of 11 beta hydroxylase, there is a clinical reflected by the clinical hypertension, but in the deficiency of a 21 hydroxylase lead to the both cortisol and aldosterone is not present, lead to the hypotension. So you have to differentiate it between these conditions lay under the congenital adrenal hyperplasia. A congenital adrenal hyperplasia has two clinical conditions according to the enzymatic deficiency, either deficiency to 21 hydroxylase, which known as salt losing state, or deficiency of 11 beta hydroxylase, which is considered salt retention state, or both of them leading to the excess of the ACTH and excessive virilization. Congenital adrenal hyperplasia due to 21 hydroxylase deficiency. More than 90% of the congenital adrenal hyperplasia are caused by 21 hydroxylase deficiency. This enzyme hydroxylate progesterone and 17-hydroxyprogesterone to yield 11-deoxycorticosteroid DOC and 11-deoxycortisol respectively, as these explained by the previous slide in the diagram. And these conversions are required for the synthesis of the aldosterone and the cortisol respectively. Both forms found in this state, either both hormones are deficient. This occurs in the most severe cases, which is non-salt wasting form of the disease, or it occurs as a slightly less severe affected patient. When in slightly less severe affected patients are able to synthesize a different amount of the aldosterone, but have elevated level of the androgen of adrenal origin. These two forms are collectively termed classical 21 hydroxylase deficiency, which occur in about 1 in 15,000 to 20,000 births in the most population. So there is two forms, either a severely salt wasting form, which is the most common, and a less severe form, which is mild form. Pathogenesis and the clinical manifestation: aldosterone and cortisol deficiency. These include progressive weight loss, anorexia, vomiting, dehydration and weakness, and hypotension, and hypoglycemia, hyponatremia, hyperkalemia. These problems typically first develop and infect infant at the age of 2 weeks. Without treatment, the patient will end in shock state, and cardiac arrhythmia and death may occur within days or weeks. Such patients may be misdiagnosed as a case of the gastroenteritis, especially in the beginning of the admission, because of presence of the vomiting and dehydration state. But when the physician done the serum electrolyte and assess the vital sign of the patient, when the result there is hypoglycemia with hyponatremia with hyperkalemia, so there is electrolyte disturbances with hypoglycemia with vomiting and dehydration, then the physician should think about this case. It is a case of congenital adrenal hyperplasia. So you have to examine the patient, examine the genitalia of the patient to see the ambiguous genitalia to reach the definitive diagnosis. Prenatal androgen excess. Also, there is a prenatal androgen excess. Affected female who are exposed in utero to high level androgen of adrenal origin have masculinized external genitals. In this slide, show a picture of the distorted genitalia, the external expression of the external genitalia, known as ambiguous genitalia, show the big clitoris and the partial labial fusion. This is manifested by the enlargement of the clitoris and by the partial or complete labial fusion. The vagina usually has a common opening with the urethra, non-urogenital sinus. The clitoris may be so enlarged that it's like a penis. Because the urethra open below this organ, some affected female may be mistakenly to be a male with hypospadias and cryptorgasm. The internal genital organs are normal because affected female have normal ovaries and not testes, and thus do not secrete anti-Mullerian hormone. So in the female, the internal organ, it is normal because they have ovaries, not testes like the male. Where the external genitalia, it is distorted and may be missed as a male. Male infants appear normal at the birth, but the diagnosis may not be made in the boys or delay until the sign of adrenal insufficiency develop. When this delay in the diagnosis, this will lead to the deterioration of the condition quickly in the male, and the infant boy are more likely to die than the infant girl, because the infant girl will result in the early diagnosis due to the presence of the external distorted external genitalia, unlike to the male which has normal genitalia at the birth. For this reason, many countries have recommended or instituted newborn screening tests for this condition to avoid of death. Postnatal androgen excess. Signs of the androgen excess include rapid somatic growth and accelerated skeletal maturation. Thus, the affected patients are tall in childhood but premature closure of the epiphysis. So there will be early or premature closure of the epiphysis, and this will result to the final adult short stature. The child in the beginning will become normal height, or the patient are tall in the childhood, but when they reach the final adult height, they result in the adult short stature. Laboratory finding of congenital adrenal hyperplasia. Patients with the salt-losing disease have typical laboratory findings associated with the cortisol and aldosterone deficiency, including hyponatremia, hyperkalemia, metabolic acidosis, and hypoglycemia, but these abnormalities may take 1 to 2 weeks to appear after the birth. So the clinical scenario of such a clinical disease came in a state of repeated vomiting, severe dehydration, with or without appearance of the cardiogenic shock. In such patient, you have to admit it as a case, an emergency case, and then assessment by the serum electrolyte. When serum electrolyte appear with hyponatremia, hyperkalemia, and metabolic acidosis and hypoglycemia, then this should be supported by sent for the blood level of 17-hydroxyprogesterone, which the result be elevated. And also with 17-hydroxyprogesterone, you should set the level for the level of the cortisone, and usually the result will be low in patients with the salt losing type of disease, in addition to the presence of the ambiguous genitalia by the physical examination. A level of the androstenedione and testosterone are elevated in the affected female, or the testosterone is not elevated in affected male, because normal infant males have a high testosterone level compared with those seen later in childhood. Prenatal diagnosis. A prenatal diagnosis of a 21 hydroxylase is made by possible late in the first trimester by the analysis of the DNA obtained by the chorionic villus sampling, or during the second trimester by aminocentesis. So the prenatal diagnosis done either by in the early first trimester by the chorionic villus sampling, or during the second trimester by aminocentesis. Treatment. Usually replacement of the glucocorticoid therapy in form of the hydrocortisone and mineralocorticoid replacement by the fludrocortisone, and surgical management of the umbilicus genitalia. Significantly virilized female usually undergo surgery or surgery between the age of 2 to 6 months of the age. Repairing surgery. Other endocrine disorder related to the adrenal gland. Congenital adrenal hyperplasia is due to the 11 beta hydroxylase deficiency. This accounts about 5% of the cases of the congenital adrenal hyperplasia, and usually this the feature may be similar to those found in 21 hydroxylase deficiency, with virilization of the affected female fetus or neonate, but just the difference in the presence of the hypertension. In cases of the 21 hydroxylase deficiency, there is case of the severe dehydration, hypotension, and cardiogenic shock maybe. Here in this disorder, there will be hypertension is important finding, and it is due to elevated deoxycorticosteroid level. And this is known as the salt retaining disorder. Lab finding in this disorder, plasma level of the 11-deoxycortisone and deoxycorticosterone are elevated. Aldosterone level are low. The treatment is the same for 21 hydroxylase deficiency. Hypertension often resolves with the glucocorticoid treatment, but may require additional therapy if it is long-standing. With calcium channel blocker may be beneficial under certain circumstances. This disorder, it is similar to the 21 hydroxylase deficiency, but difference in one point: there will be hypertension, and known as a salt retention disorder. The same treatment, but differ in the same treatment. But may we add additional therapy of antihypertensive cases if it is long-standing. Other disorder in the endocrine: short stature. Accurate measurement of the height or length and weight should be plotted on the growth chart for the timely diagnosis of the growth disorder. What mean by the arm span? Arm span is measured as the distance between the tips of the fingers when the patient holds both arms are stretched horizontally while standing against a solid surface. Short stature is defined as subnormal height relative to other children over of the same sex and the age, taking family height into consideration. The presence of the height 3.5 standard deviation below the mean, or the height velocity below the 5th percentile for age, or height below the target height corrected for the mid-parental height, require diagnostic evaluation. Children, when we take the height of these children and put it on the growth chart and see the height of this child is below the 5th percentile for age, this means the patient has a short stature. Causes of the short stature. First, familial. Most short children have short parents and fall within the centile target range, allowing for the mid-parental height. Care needs to be taken that both the child and the parent do not have an inherited growth disorder. So these children has no any disorder related, inherited, or other disorder. They look like normal. This height pattern, it is similar to their family. Intrauterine growth restriction or extreme prematurity. Intrauterine growth retardation. About one-third of the children born with severe intrauterine growth retardation or who were extreme premature remain short. So expected the premature infant have the short stature in the future. Endocrine hypothyroidism, growth hormone deficiency. Growth hormone deficiency considered little a bit as a common cause of the short stature, and steroid excess are considered uncommon cause of the short stature. Constitutional delay of growth and puberty. These children have delayed puberty, and it is common in male, and it is violation of the normal timing of the puberty rather than the abnormal condition. An affected child will not show the same sexual changes as is pairs, and bone age would show moderately delayed, and this constitutional delay is different from the familial short stature. Their bone age is delayed, where in familial short stature the bone age is not affected, and even eventually these children would reach the target height will be normal. يعني it is just delay in the time of puberty, started as a short, but the final adult height will be normal. Nutritional and chronic illnesses. There is a relatively common cause of abnormal growth, and these children are usually short and underweight, like celiac disease, Crohn's disease, chronic renal failure, or congenital heart disease. So any chronic disease, they affect the height of the children, and the end result will be short in addition to the under. Psychosocial deprivation. Children suspected to the physical and emotional deprivation may be short and underweight and show delayed puberty. This condition may be extremely difficult or impossible to identify, but affected children show catch-up growth if placed in the good environment. So these children underlying the psychosocial deprivation, when change the mode of the environment and become a suitable and good environment, then these children will be show catch-up growth and acceleration of their height. Chromosomal disorder or syndromes. Many chromosomal disorder and syndrome are associated with the short stature, like Down syndrome and Chernow syndrome, Nonance syndrome, or the Silver syndrome may be present with the short stature. This is the method for taking the height of the children, and this is for the infants. Thank you.